What's up, Ninja Nerds? In this video today, we're going to be talking about hyperthyroidism. But before we get into it, please continue to support us by hitting that like button, commenting down in the comment section, and please subscribe. Also, to help you guys out through the learning experience in this video, down in the description box, we'll have links to our Patreon. If you guys join, we'll have comprehensive notes and pictures that are going to be drawn before the whiteboard is actually filled out and after the whiteboard's filled out for you guys' enjoyment. So go check that out. All right, Ninja Nerds, let's get into it. All right, Ninja Nerds, so before we start talking about the actual pathophysiology behind hyperthyroidism, I think we really need to have a quick little discussion on the basic physiology of the thyroid hormone. We're not going to go into crazy depth. If you guys want more depth on it, go into our actual video where we cover thyroid hormone's effect on target organs, okay? But let's start off talking a little bit about thyroid hormone physiology. You guys need to know the first part of thyroid hormone physiology begins in the central nervous system, in a particular area of the central nervous system referred to as the hypothalamus. So this first structure here that you need to know is the hypothalamus. The hypothalamus is kind of your master endocrine regulator. And what it does is it releases a hormone called thyrotropin releasing hormone, also known as TRH. The TRH then circulates through what's called the hypophyseal portal system and comes down to this next area where you have some thyrotrope cells located in the anterior pituitary. Once it gets to the anterior pituitary, it stimulates the anterior pituitary to make a hormone called TSH. So remember, hypothalamus TRH stimulates anterior pituitary to make TSH. Then TSH circulates through the blood where it goes and acts on the thyroid gland, but particular at the microscopic level. If we were to really zoom into it, they're on the follicular cells. So what I'm going to do is I'm just going to take like a piece here of follicular cell and zoom in on it so you guys can see what's happening here. So what happens is TSH actually comes and binds onto one of these thyroid follicular cells located within the thyroid gland. And you see this little blue receptor here? That blue receptor is what TSH binds to. And this receptor is called the TSH receptor. Very important. Need you guys to remember that one. When TSH binds to the TSH receptor, what it does is it sends intracellular signals to the nucleus. And once it actually activates particular genes located within the nucleus, it leads to the synthesis of a particular protein, and that protein is kind of spit out of the follicular cells into a central portion, which I'll show you in a second. And that protein that it makes is called thyroglobulin. Okay, so that's the first thing I need you to know that TSH does, is it acts on the TSH receptor, and the first thing it does is it increases the expression of a particular gene that codes for thyroglobulin. The second thing that it does is it comes down here and stimulates this particular enzyme. And this particular enzyme, I'm going to abbreviate it, is called thyroid peroxidase. TPO, we're going to abbreviate it as. It stimulates the activity of this enzyme, which I'm going to tell you what it does in just a second. But in order for this enzyme to work, it needs a particular type of ion. You know these follicular cells, they really love iodine. Okay? And so what happens is there's iodide transporters located on the follicular cell surface. And what happens is iodide gets brought into these cells via these little sodium iodide symporters. And once in these cells, it then gets pumped out of the follicular cell and into the central portion of the follicle. So now I have my iodide out here. And TPO does a couple things. One of the things it does is it converts iodide into iodine. Don't worry too much about that. But here's what I do want you to know. Once TPO is activated, it takes iodine and the thyroglobulin and combines them together. So it's going to stimulate this step. TPO will stimulate this step. It's going to take iodine and thyroglobulin and combine it together. And what's going to happen is you're going to make, we're going to write this as iodinated thyroglobulin. And interestingly enough, iodinated thyroglobulin, inside of it, it's a big protein structure with a bunch of iodines on it. Thyroid hormone is incorporated into it. What happens is the iodinated thyroglobulin is then taken back up into these follicular cells. And a couple different enzymes will break down the iodinated thyroglobulin, little proteases. And from there, after it's taken back into the cell and it has what's called a proteolysis, it releases thyroid hormone from the iodinated thyroglobulin in the form of T3, which is called triiodothyronine, and T4. This is your thyroid hormone. Now here, really quickly, just so we have a basic understanding. T3, how many iodines do you think we added on to these tyrosine amino acids? 3. How many do you think we added on to the thyroxine or T4? 4. So thyroglobulin is a bunch of, has tyrosine amino acids, and we add iodine onto it, and then what we bring it into the cells, we cleave these portions out of it. Now, once we've made our T3 and T4, and it gets into the blood, then where does it go? That's the next important thing. It goes to various tissues, but what I want us to focus on is most cells in our body, most nucleated cells in our body, it has the same, pretty much the same metabolic effect. So the most abundant between these two, if you had to pick which one of these is actually made most from the thyroid follicular cell and circulating through the blood, which one is in higher concentration? It's usually T4. So T4 is going to be about 90% of what's produced from the thyroid follicular cells. Once it gets to these tissue cells, it just passes across the cell membrane. And once it gets into the cell membrane, there's particular enzymes, I don't want to focus too much on them, but they're called deiodinases. What do you think that means? They remove an iodine and convert T4 into T3. And then what happens is T3 acts on particular genes within the cells and increases the expression of proteins. And there's so many proteins that it produces that carry out a lot of metabolic effects. But the most important one that it produces is it increases the expression of what's called sodium potassium ATPases. Okay, the sodium potassium ATPases, or sodium potassium pumps, we sometimes refer to them as. Why is that important? Let's really take a quick second here to understand. If I express a lot of these sodium potassium ATPases, and what they're doing is they're pumping what? 3 sodium out of the cell, and they're pumping 2 potassium ions into the cell. But in the process, they're utilizing a lot of ATP. So what's going to happen if I have a lot of these sodium potassium pumps? I'm going to have a lower ATP because I'm using so much of it. Well, how do I generate more ATP within my body? I break down molecules that give me energy. What are those molecules that our cells break down to generate a lot of ATP? What are those particular metabolic pathways that I know you guys remember from biochem? One is we break down glycogen, glycogenolysis. You know what this is, right? This helps to break down glycogen into glucose and then use it for ATP formation. The other one is glycolysis. So any of the glucose that I have in the cell, I'm going to break it down into pyruvate, acetyl-CoA, Krebs cycle, and make ATP. Or I'm going to break down lipids, and I'm going to use that for energy. So all of these processes, I'm increasing the metabolism of these things, right? The process of doing that increases your metabolic activities. You know what else is important about this? What's a byproduct of metabolism, cellular respiration? You generate CO2, water, and what else? Heat. So whenever your cells are super active breaking down glycogen, breaking down glucose and lipids, what else are they producing as a byproduct besides CO2, besides water? They're also producing lots of heat. So what we know is that the biggest effect of thyroid hormone is it helps within these metabolic pathways, enhancing them. What does it do? It enhances the activities of these pathways. Because why? Your body's using more of these pumps, depleting the ATP, so you need to generate more ATP with these processes. And by doing more of this process, you generate more body heat. And so it increases the body temperature of the individual. Makes sense, right? Okay. Now that we understand this, that's very important because all the other stuff, we're just going to kind of breeze through. Again, if you guys want more detail, go watch our video on the effect of thyroid hormone on target organs. But let's talk about the basic effects of thyroid hormone on all the other cells within the body, or tissues in the body. Big thing I want you to remember here is that it increases the sensitivity of beta-1 adrenergic receptors. What the heck binds to those? Epinephrine, norepinephrine. If more epinephrine, norepinephrine binds onto those receptors and you increase the sensitivity of them, what's it going to do? It's going to increase the heart rate. And it's going to increase the contractility. And whenever you increase contractility, what does that produce? Stroke volume. Remember, increasing contractility increases stroke volume. And so the combined effect of these is that you can increase cardiac output with this. That makes sense, right? So that's the basic effect here. Within the bones, the big thing that you need to remember is that it maintains a beautiful balance between osteoblasts and osteoclasts. So big thing to remember is it maintains a balance between osteoblast and osteoclast. That's super important, okay? It maintains a balance. What do osteoblasts do? Deposit calcium into the bone deposition. What do osteoclasts do? Pull calcium from the bone resorption. Maintains a beautiful balance. What does it do to the nervous system? It increases the activity of what? Your sympathetic nervous system. So that's going to be your fight or flight type of effect. It's really going to increase the adrenergic drive within the body. So really remember that it can increase the activity of the sympathetic nervous system. The other thing is it acts on our GI tract, and it actually can act on the smooth muscle, and it increases the GI motility. Not only does it increase motility, but it can also increase some of the secretions that come from the GI tract as well. The next thing is it acts on the skin. And it's very interesting within the skin. When it acts in the skin, it actually, you know these little blood vessels in the dermis? It actually increases the blood flow through the dermal capillaries. If you increase cutaneous blood flow, how will that help the hair, the skin, the nails? All of that is important for growth. You need oxygen, you need nutrients for those cells to continue to keep replicating and growing. So it increases cutaneous blood flow, which is important for hair, skin, and nail growth. It also acts on the sebaceous glands and the eccrine sweat glands. So it maintains secretions from the skin. So what else does it do? It maintains the secretions from the skin. Okay, what kind of secretions? Sebaceous, which is oily secretions, and eccrine, which is kind of your normal sweat secretions. It also acts on the reproductive system. You know, within the reproductive system, we have the effect of our reproductive development. So it's important within the development of the reproductive system. So what does it do? It's involved in the development of the reproductive system. Okay? The next thing, it's very, very important that you guys remember this. Thyroid hormone levels regulate the activity of sex hormone binding globulin, which we'll talk about a little bit later. So it also regulates sex hormone binding globulin levels. Beautiful. Okay. The next thing is that it acts on fibroblasts. And when it acts on your fibroblasts, it likes to stimulate the fibroblasts to produce a particular type of molecule. You know, these fibroblasts, they produce a lot of different types of connective tissue that are important for our extracellular matrix. Well, one of the big things that it does for fibroblasts is it increases the secretion of what's called glycosaminoglycans, also known as GAGs. And it also is important for other extracellular matrix proteins. So it helps with the production of lipopolysaccharides like glycosaminoglycans and extracellular matrix proteins. Last but not least, it also acts on our muscle tissue, our skeletal muscle tissue. And it plays a role within the muscle contraction. So it plays a role in normal muscle contraction. It can kind of enhance muscle contraction. It also can increase the regeneration and growth of the skeletal muscles. So that covers the basic functions of thyroid hormone on various target organs. All right, so now that we kind of brushed up on our quick thyroid hormone physiology, now let's talk about the causes for someone having hyperthyroidism. There's a couple different reasons. The big one that I really want us to focus on is the hyperfunctioning thyroid gland, okay? The thyroid gland is producing too much thyroid hormone. And it could be something intrinsically wrong with the thyroid, meaning it's a primary issue, or it could be something else that's stimulating the thyroid gland, telling it to make a lot of thyroid hormone. And that's a secondary hyperthyroidism. Let's focus on the primary hyperthyroidism causes, represented by these top 3 thyroid glands. The most common primary hyperthyroidism is referred to as Graves' disease. And the second one here is they develop these like large nodule here. It's called a toxic adenoma. And the last one is they develop multiple nodules within the thyroid gland, and so we call this a toxic multinodular goiter. These are the three most common causes for someone developing primary hyperthyroidism. Now, let's talk about the reasons that they develop this. Graves' disease is primarily referred to as an autoimmune disease. And without really digging into the details in this, what I want you to understand with this autoimmune disease is that with an autoimmune disease, there's a genetic component and an environmental component. The genetic component is the real big thing that I want you to remember. And what happens is that your immune system cells, let's say that they're exposed to an environmental trigger. And from that, they generate an immune response. Because they have these genetic susceptibility genes, mutations within these genes, they develop an exaggerated immune response and develop antibodies that attack our own tissues. The genetic susceptibility genes that I need you guys to remember that are associated with Graves' disease is HLA, DR3. These are the big things I need you to remember. Now, remember I told you, immune system responds to an environmental trigger, susceptibility genes cause an exaggerated immune response, plasma cells produce antibodies that attack the actual thyroid gland. I need you to know the particular mechanism of those antibodies that are produced. The antibodies that are produced for Graves is TSH receptor antibodies. Very, very important. Do you guys remember what thyroid hormone, what TSH, thyroid stimulating hormone, does to the thyroid follicle cells? It stimulates thyroid globulin production and stimulates thyroid peroxidase, which also helps with thyroid hormone synthesis. Guess what these antibodies do? They stimulate the TSH receptor. If you stimulate the TSH receptor, what the heck is that going to cause? That's going to increase T3 and increase T4 production, causing hyperthyroidism. That makes sense. So that is the big thing I need you to remember with Graves' disease. Okay, toxic adenoma and toxic multinodular goiter are actually very easy for the most part. What happens with these is they have these nodules, okay, and these nodules that are developing, and they're just basically clumps of thyroid follicular cells. But what happens is for both of these, toxic adenoma and toxic multinodular goiter, their reason that they cause a lot of thyroid hormone production is due to a TSH receptor mutation. Now what happens is they mutate the TSH receptor where it can auto-activate itself. If the TSH receptor can auto-activate itself, what does it do? Stimulates thyroid globulin synthesis, stimulates the thyroid peroxidase, stimulates thyroid hormone production. That's how it produces a lot of thyroid hormone. So what does it do again? It auto-stimulates TSH receptor because of that mutation, which results in increased T3 and increased T4 production. That is beautiful and that makes perfect sense, right? So these causes here are most likely the reason for a primary hyperthyroidism. So now we understand the primary hyperthyroidisms. Now let's talk about secondary hyperthyroidism. So secondary hyperthyroidism means that it's not associated with the problem being the thyroid gland. It's some other area that's stimulating the thyroid gland. The most common cause for secondary hyperthyroidism is a pituitary adenoma, which is just like a little tumor. Well, sometimes it can be a little bigger. A pituitary tumor that's going to be kind of secreting a lot of a particular type of hormone that we know that it produces. What hormone do you think that this pituitary tumor is going to release a lot of? It's going to release a lot of TSH, thyroid stimulating hormone. What does thyroid stimulating hormone do? Acts on the thyroid gland. Acts on the TSH receptors, increases thyroid globulin synthesis, increases the thyroid peroxidase activity, and increases thyroid hormone production. So as a result, you're going to have increased T3 and increased T4, but please, for the love of goodness, do not forget that the problem is high TSH. That is important, because you want to know what happens? We'll talk a little bit later. There's a negative feedback mechanism. Whenever thyroid hormone levels are high, normally, what does it do to the pituitary gland? You guys remember your physiology? It should tell the pituitary gland, hey, there's too much of me, stop making TSH. And then the less TSH means less thyroid hormone production. If you have a pituitary tumor, this high thyroid hormone will go back and tell the pituitary, hey, there's too much of me, But guess what? The pituitary won't listen. It says, baby, I'm going to keep producing TSH. And the TSH will keep rising and keep producing more in T3 and T4. That's important and one of the biggest differences between primary and secondary hyperthyroidism. Okay, the other less common cause, very annoying one to remember, is related to an increased amount of beta HCG. You're like, what the heck? What does this have anything to do with it? I thought that was a pregnancy. It can be. When people develop these little tumors, okay, these little tumors, there's a bunch of different types of tumors, but the two most common tumors that you guys need to remember here is what's called a molar pregnancy. And a molar pregnancy, there's a particular type called a hydatidiform mole, so pregnancy. And then the other one is called a choriocarcinoma. These are tumors that develop within the uterus, and they produce lots and lots of beta HCG. You're like, what the heck does that have anything to do with this? You know, whenever you have high levels of beta HCG, it can act like TSH. And this high levels of beta HCG will stimulate the thyroid gland like TSH does and tell the thyroid gland, hey, make a lot of thyroid hormone, baby. And that's what the thyroid gland does. And it ups its T3 and it ups its T4 production. But remember, the underlying cause for this is a molar pregnancy or choriocarcinoma. What will happen? The T3 and T4, right, those levels will be increased. And if the pituitary is fine, which it should be, what will the pituitary gland do? If it's fine, it should shut down the TSH production and then decrease thyroid hormone production. But the beta HCG is just going to continue to keep producing this, continuing to produce thyroid hormone. So I want you to remember, even though you have high T3 and T4 and you also have a corresponding low TSH, it still could be secondary, but it's because of a high beta HCG production. Okay? Okay, now that we talked about the hyperfunctioning thyroid issues, primary, secondary, the next reasons for someone developing hyperthyroidism is because you jacked up their thyroid gland and caused all those follicular cells to just bust open and release the thyroid hormone out into the blood. And here is I can't stress this enough, you guys need to really remember this. This destruction of the thyroid tissue, when it causes the follicles to bust open and release their thyroid hormone, it is only transient, meaning it's a temporary hyperthyroidism. Okay, it doesn't last long. And I'll explain why in just a second. So let me quickly explain why. You destroy the thyroid gland, right? For whatever reason, we'll talk about the reasons, but you destroy the thyroid gland made up of follicular cells. Those follicular cells get destroyed. They release thyroid hormone. If that continues to keep happening over and over and over again, you destroy more and more follicular tissue. Over time, that follicular tissue is no longer able to produce thyroid hormone. And so because of that, what do they start converting into after had this transient period of hyperthyroidism? After you destroy enough follicular tissue, it'll then progress into hypothyroidism. I can't stress the significance of this enough. When you destroy the thyroid gland, these causes produce a transient hyperthyroidism. But with continued destruction of the thyroid tissue, this can lead to hypothyroidism. Okay, beautiful. So now that we understand how this is happening, and really quickly, I didn't explain this before, but here's what I meant by, you have a thyroid follicle, it looks like this. And then you have the follicular cells that are surrounding the edge of it. Okay, that's your follicular cells, all of these. In the center of the follicular cells is the thyroglobulin. Very, very important. What is this structure here again? Thyroglobulin. What are the cells around it? Follicular cells. Remember I told you that the follicular cells are the ones that are releasing what? T3 and T4, which I'm representing with all these blue dots. Okay? When you destroy these thyroid follicles, what busts out of them? More thyroid hormone. But here's the next thing. If I destroy the thyroid follicles, watch, I destroy the thyroid follicle. Now what happens? Some of this structure inside of the thyroid follicle can leak out. What is that substance that can leak out of this thyroid follicle? Thyroglobulin. So I need you guys to remember that whenever there is destruction of the thyroid gland or thyroiditis, they can spill thyroid hormone out, causing a transient hyperthyroidism, but can also spill what else out? Thyroglobulin. That's an important diagnostic tool. Okay? All right, beautiful. Now that we understand that, what are the causes? Pretty straightforward, pretty simple. First one is antibodies. Antibodies are actually attacking particular portions of the thyroid follicles. You know which structures are being targeted by these antibodies? The big ones is you have what's called anti-TPO antibodies. What were those? Anti-thyroid peroxidase antibodies and anti-thyroglobulin antibodies. If I'm producing a lot of anti-thyroid peroxidase antibodies and a lot of anti-thyroglobulin antibodies, these are very important in thyroid hormone synthesis and important for the thyroid follicles. If I produce these, they're going to damage the follicular cells. And then what's going to be released out of these follicular cells? What two things? I'll represent the blue dots with thyroid hormone. I'll represent the red dot with thyroglobulin. What are the two most common causes for these anti-TPO and anti-thyroglobulin antibodies? The first most common is seen with Hashimoto's thyroiditis. This is going to be the most common type. The second one is called postpartum thyroiditis. And this can occur up to 1 year postpartum, okay? The reason for Hashimoto's producing these thyroid antibodies is due to an autoimmune disease that we'll discuss in further detail in hypothyroidism. But it's genetic susceptibility genes similar to Graves' disease. Postpartum, we don't know why the antibodies are produced, but we know that they're attacking these particular proteins that are important in the thyroid follicle. The next important cause, you see this little bugger right here, this little pathogen? We're going to call this little pathogen here a virus. And this virus is going to attack and injure these thyroid follicles. As it injures the thyroid follicles, what's going to spill out of these thyroid follicles? Thyroid hormone. What's going to spill out after that? Thyroglobulin. What is this called whenever a virus infects these follicular cells and causes this thyroiditis? It's got one heck of a name. There's actually a couple names for it. It's called subacute granulomatous thyroiditis. Also sometimes referred to as de Quervain's thyroiditis, okay? So that's another cause, okay? The next one is drug-induced. And there's two particular drugs that I need you guys to remember. So this is going to be some type of drug or medication that's associated with causing injury to the thyroid tissue. And again, if it injures the thyroid tissue, I know this is so repetitive, but it's worth it because it's going to stick within your brain. It's going to release lots of thyroid hormone from it, and then it's going to release lots of thyroglobulin from it. There's two particular drugs I need you guys to remember that can damage the thyroid gland. Very important. The first one is amiodarone. We use this in arrhythmias, right? The next one is lithium. And what do you use this in? Primarily bipolar disease, okay? So these two things can really jack up the thyroid gland and cause some thyroiditis, causing this transient hyperthyroidism over time, hypothyroidism. The last one is really the weirdest one, but it's probably one of the cooler ones, is whenever someone is receiving too much iodine. And they're receiving too much iodine, and this iodine gets taken up into these cells, right? These thyroid follicular cells. And when it gets taken up into the thyroid follicular cell, something interesting happens. In people, okay, who are iodine deficient, okay, or have a toxic multinodular goiter, or have Graves' disease, okay, they're hungry for this iodine. And they'll take up the iodine really heavily, and they use it. Why are they going to use it? They're going to use it to produce a lot of what? Thyroid hormone. Lots of it. But what happens is that iodine inside of our cells can start to cause a lot of reactions and damage to our tissues. So over time, it's going to cause inflammation to the thyroid gland and destroy some of the thyroid tissue, and that's going to start releasing more of that thyroglobulin as well as more of the thyroid hormone. There's a particular name for this whenever you give a lot of iodine to iodine deficient individuals, ones who have hyperfunctioning thyroid tissues, and they make a lot of thyroid hormone. It's one heck of a name, but it's a pretty cool one. It's called the Yod-Basedow phenomenon. Okay? So now that we understand how destruction of the thyroid gland, and again, what's the term that I really kind of want you to take associated with this? Thyroiditis inflammation of the thyroid gland, causing a transient hyperthyroidism. After continuous damage, they develop hypothyroid. We talked about the causes. We know the particular conditions. Now let's move into the less common causes associated with hyperthyroidism. One is someone's taking thyroid hormone. And you got to think about this two ways. Okay, you have to ask yourself the question, do they have a past medical history or current medical history of hypothyroidism? And they're taking thyroid hormone, but they're taking too much of it. They're taking too much of their thyroid hormone, and that's why they have a hyperthyroidism. Or they have what's called factitious hyperthyroidism. And this means that they don't have any hypothyroidism. They're just taking thyroid hormone to get yoked for some reason or to lose weight because it increases your metabolic activity, right? So these are the two things that you have to be thinking about. When you're thinking about someone having hyperthyroidism, do they have a history of hypothyroid? Oh, I might be giving them too much thyroid hormone. Or do they not even have hyperthyroidism and they're just taking this medication to lose weight? That could be factitious hyperthyroidism. The last one, and the USMLE used to love to ask this one, is you figured that there's no problem with the thyroid hormone at the thyroid gland. There's no problem with the pituitary. There's no problem with the thyroiditis, or that they're not taking thyroid hormone. The last thing you want to be thinking about is what's called ectopic thyroid hormone function. Meaning, in other words, you're making thyroid hormone, but you're making it from a tissue that's not the thyroid gland. It's a tumor that develops on the ovary, and this tumor develops thyroidal tissue that can produce thyroid hormone and exert the effect of hyperthyroidism. This tumor is called a struma ovarii. And this is the last thing that I want you guys to remember for the potential causes of hyperthyroidism. Now that we've gone through the causes, let's understand how now we've produced a lot of hyperthyroidism due to these underlying causes. How does that exert clinical features that we experience when we're examining these patients? All right, so now let's talk about the pathophys. So now we have a complete, strong understanding that we have a lot of thyroid hormone, lots of it, okay? And this thyroid hormone is going to start exerting its effects on various different tissues. You guys remember the physiological effects? I know you guys do. Let's go through and say every physiological effect that we talked about, just amplify it. So we know that it's going to act on the following tissues. Cells, most cells in our body, nucleated cells that can produce sodium potassium ATPases. Utilizing more ATP, needing to create more metabolic pathways. What is that going to do? It's going to increase glycogenolysis, increase lipolysis, increase glycolysis, and this increased metabolic activity is going to do what? If you break down more glycogen, you break down more glucose, you break down more lipids, it's going to lead to weight loss. You're going to have a lot of weight loss because you're breaking down all that good stuff. I wish I had some of that sometimes. The next one is it's also going to generate a lot of heat. And if you generate a lot of heat, what's that going to do? That's going to increase the body temperature. Okay, so they'll have an increased body temperature, they'll have weight loss, increased metabolic activity. Okay, now that we have a pretty good understanding of how that is one of the big things, the next thing is it acts on the heart, increasing the sensitivity of the beta receptors on the heart tissue. That's going to increase the heart rate. What is that called whenever we increase the heart rate above the normal rate? Tachycardia. It's going to increase the contractility of the heart. And if you increase the contractility of the heart, you're going to increase the stroke volume. The combination of that is that you're going to increase cardiac output, and the effect of having an increase in cardiac output is that this can lead to hypertension. So the two big things to remember here is that it can cause hypertension and tachycardia, okay? The next thing is it can act on the bone tissue. When it acts on the bone tissue, what do we say it does? Maintains a nice little beautiful balance between what? Osteoclasts and osteoblasts. Well, guess what? When it's too high, it favors osteoclasts. If you increase osteoclastic activity, what is that going to do? That's going to increase bone resorption. You're going to pull more calcium from the bone. As you increase bone resorption, what is that going to cause? It can make the bones more osteoporotic. And if you cause some porosis of the actual bone, osteoporosis, in elderly individuals who maybe are already susceptible to osteoporosis, what can that do? They fall, crack a hip, right? And that's going to lead to fractures. So that's the big thing to remember for this one. The next thing, We said it increases the sympathetic nervous system drive. If you increase the activity of the sympathetic nervous system, there's a couple things that happen here. One is, what happens if you're in this fight or flight mode all the time? You're anxious. So some of the things that it'll produce is anxiety. And what happens if you're really worked up when you're trying to sleep? You can develop insomnia. And if you're just always worked up, you're not getting a lot of sleep, you're going to be, I'm going to be irritable. So it can develop a lot of irritability. And the big thing here that I want you also to remember is that it acts on, this is the interesting one. You know the sympathetic nervous system? It acts on the levator palpebris superioris, and it causes that to contract, which kind of yanks up the eyelid. What if I have too much sympathetic drive? It's going to yank that sucker all the way back. And that's called lid retraction with lid lag. So they can develop lid lag and lid retraction. So that's another big thing to be thinking about, and that's due to the increased stimulation to the levator palpebris superioris, which is sympathetically innervated. Boom, we're on a roll, guys. Remember, we increase the activity of the GI motility. We increase GI secretions. What is that going to do? I'm going to be peeing out my butthole. So now I'm going to have diarrhea. And the problem with diarrhea is that this can cause a decrease in the volume in the blood and may lead to some slight hypovolemia in certain situations if it is severe. In the same way, whenever someone has an increased body temperature, they're going to have to sweat a lot. That's their natural response when you have an increased body temperature. That increased sweating may also cause some decrease in blood volume as well. So you got to be watching out for them to become dehydrated as well. All right, boom, we hit that. Let's move up to the muscles. It acts on the skeletal muscles, increasing contraction of the muscles, trying to increase the growth of the muscles. Whenever the muscles are trying to have this increased contraction and increased growth, believe it or not, they start to get irritated and painful. And when they become irritated and painful, this produces what's called a myopathy, which is inflammation of the skeletal muscles. But here's what I need you to remember. The skeletal muscles don't get damaged. They don't get injured and release a very beautiful enzyme out of them. You know what the enzyme is that's found within muscles? Creatinine kinase. So I need you to remember that there is myopathy, but their creatinine kinase is normal because there is no damage to the actual muscles, that they're not popping open and releasing this, or that they're not regenerating properly. Okay? The next thing, we're increasing cutaneous blood flow to the hair, the skin, the nails. You're going to increase the growth. You're going to have beautiful locks. All right? I definitely got to take thyroid hormone. So it's going to increase hair growth. Okay, so they have like coarse hair. It's going to increase the growth of the nails. And something interesting about that, the thyroid hormone, when it's too much, it's actually causing lots of growth of the nail. And what happens is sometimes the nail separates from the nail bed and produces onycholysis. Okay, so it produces onycholysis. Okay, so that's the first thing I want you to remember. The next thing is, remember, what else did we say it acts on? The sebaceous glands and the sweat glands. So it's also going to increase sweating, so they may be diaphoretic, and increase sebum production. Okay, and so they may have a little bit more oily skin. Also, it increases blood flow to the skin. So what's the skin going to look like? Nice and flushed, right? Have a nice little good hue to it. So again, that's the effect that it can have on hyperthyroid effect on the skin. All right, next thing. Remember I told you it has an effect on the reproductive system. Well, it's kind of an interesting way that it does that. Not only is it important for the development of the reproductive system, but remember I told you it plays a role with regulating sex hormone binding globulins? Let me explain what I mean. Whenever you have a high amounts of thyroid hormone, high T3 and high T4, that acts on the liver. And it causes the liver to produce one particular hormone that we'll put over here that actually binds to thyroid hormone and circulates it through the blood. Because technically, thyroid hormone is a steroid-like hormone. And the hormone that the protein that the liver produces is called thyroxine binding globulins. And so it binds with the T4, which is the 90% of the thyroid hormone that's circulating in the blood, and takes it to the cells. But whenever there's this high thyroid hormone, it produces more and more thyroxine binding globulins. But with it, it produces other globulins that are similar to it, called sex hormone binding globulins. You know what these things bind? They bind estrogen and they bind testosterone. So let's put over here, they'll bind an E for estrogen, and they'll bind over here testosterone. If you have a lot of these sex hormone binding globulins, they're gonna bind a lot of estrogen and bind a lot of testosterone. What does that do? And then you're gonna have low circulating estrogen in the blood, and you're gonna have low circulating testosterone in the blood. That means less of this hormone to exert its metabolic effects on the body. In males, what would be the problem if you have low testosterone? You're gonna have decreased libido, right? So this will cause low libido. It's also needed for sperm production, so they'll have decreased sperm production. And it also is important for masculinization. So what it's gonna happen, they're gonna develop some man boobies, and it's called gynecomastia. So these are the things that can happen because you have too much of this sex hormone binding globulins and less circulating testosterone. All right, so what about in females when they have low circulating levels of estrogen? That's gonna do what? Well, it's involved in the ovarian cycle and ovulation. And so because of that, they can develop anovulation, which is when they don't actually produce an oocyte and pop a little oocyte out that can be fertilized. So they can develop infertility. So an issue with this is they could develop infertility because of the ovarian cycle effect, right? The other thing is that it's involved in the menstrual cycles. And it's important for helping with the menstrual cycles. And if you don't have a lot of circulating estrogen, are you going to be able to stimulate the menstrual cycles to occur regularly? No. So because of that, they occur less regularly and less often. And this can be, if they occur less often, oligomenorrhea, or they don't occur at all, amenorrhea. These are things that I need you guys to remember as well, okay? All right, the last thing that I need you guys to think about here. One more, it's a really interesting one. If there's a lot of thyroid hormone, the other thing it does is it increases the expression of LDL receptors and takes in lots of LDL. So if someone has a lot of thyroid hormone, they take in a lot of LDL into the liver and lower their circulating LDL levels. Oh, that's good. Wouldn't you want that? Absolutely. So one other effect that I want you guys to remember is that this also, thyroid hormone can increase the expression and activity of the LDL receptors. And you take in more LDL, and so the effect of that is you'd have decreased LDL in the blood. That's beautiful. That's pretty cool. All right, the next thing, and this is the one that's particular to Graves' disease that I need you guys to remember. So let's actually kind of put a little note here on the side that this is only particular, this here, particular to Graves' disease. Okay. Remember these antibodies? What are these antibodies again? Those TSH receptor antibodies. These TSH receptor antibodies, sometimes what they can do is they can activate T cells within our body. You know where these T cells are most particularly stimulated? Believe it or not, in the retroorbital space. And what happens is these T cells in the retroorbital space become super stimulated by these TSH receptor antibodies. And they start producing a lot of interferon gamma and a lot of tumor necrotic factor alpha. And these start stimulating a lot of the fibroblasts that are located in that retroorbital space. If I stimulate a lot of these fibroblasts, do you guys remember what the fibroblasts produced? The big thing I need you guys to remember? The GAGs. There's an increase in the glycosaminoglycans. What did I say GAGs do? They hold on to lots of water. Well, there's other tissues besides fibrous tissue that's located within the retroorbital space. Muscles, all your erectile muscles, and fat tissue. If I have lots of GAGs, I'm going to pull lots of water into the muscle tissue and lots of water into the tissue around the adipose, swelling it up. So that's going to induce what? Some swelling of these tissues. Also, not only do GAGs increase water accumulation around these tissues, but it also increases the number of adipocytes. So it's going to cause swelling and increase the adipocyte count. And as you do that, think about what happens. As I swell the muscles behind my eye, I increase the amount of adipose tissue behind the eye. What's it going to do? There's only a little bit of space now. Boing! it's going to pop the eyeballs out and it's going to cause exophthalmos. Okay? So what is the result out of this? The effect of this is going to be exophthalmos. Okay. Last thing I need you guys to remember here is that the TSH receptor antibodies not only can act on the T cells in the retroorbital space, but they can directly stimulate the fibroblasts located in our dermis. So here, let me draw like a little dermal fibroblast that's located here. Okay? We're just zooming in on it. These antibodies, let's do it in blue here, can directly stimulate these fibroblasts. They produce a lot of GAGs. Where? In the dermis. If they produce a lot of GAGs into the dermis, what's it going to pull into the dermis? Lots of water. If I pull lots of water into the dermis, what's that going to cause? Edema. But this edema, you know where it's most commonly found? In front of the tibia, the pretibial area. So this, a lot of water due to a lot of GAGs in the dermis is going to produce a particular type of edema called pretibial myxedema. Okay? And again, very, very important that you guys remember that this is most commonly, pretibial myxedema and exophthalmos is most commonly particularly seen with Graves' disease. Okay? We killed the pathophysiology, ninja nerds, and now let's hit up our diagnostics. All right, ninja nerds, so now let's talk about the diagnosis of hyperthyroidism. So the first thing that we need to do is there's a couple steps, 4 steps to determining if someone has hyperthyroidism. First thing that we need to determine is it primary or secondary? In other words, is it a thyroid issue or is it a pituitary issue? Let's remember our feedback mechanisms, ninja nerds. Whenever you're trying to determine is it primary versus secondary, what test do I order? I order thyroid function tests. And with the thyroid function test, you get T4, free T4, and you get TSH, thyroid stimulating hormone. Those are the 2 things that you get with that test primarily. Okay? So, if it is a primary issue, okay, so let's say here, it's a primary issue. What was the problem with this one? The thyroid gland was the issue. It was producing too much thyroid hormone. So if it's a primary thyroid issue, this means that you're going to have high free T4 because it's making a lot of thyroid hormone, right? But if there's a lot of thyroid hormone, what does it do? If the pituitary is fully normal, it'll tell the pituitary, hey, too much of me, stop making TSH. And the TSH levels should decrease if the pituitary is normal. So in primary, they'll have high free T4, but they'll also have low TSH, assuming that the issue is, there's no problem with the pituitary gland, okay? If it's a secondary issue, you have to remember here that, again, the pituitary is the most common problem. It's making a lot of TSH. A lot of TSH is stimulating the thyroid gland to make a lot of thyroid hormone. So because of that, they're going to have a lot of thyroid hormone, but again, a lot of that thyroid hormone is being produced. The pituitary is all jacked up. It's not listening to what the high thyroid hormone is saying. It doesn't stop making TSH. It keeps making TSH, and the TSH levels will be high. That is the big differentiating factor between primary and secondary. But remember, there was one little extra one that I wanted to add in, that beta HCG issue. Let's say that you check. Okay, maybe the patient is coming in with symptoms that are presenting something like this. Maybe they're having uterine bleeding. Maybe they're having lower pelvic pain, or they're having they tested positive on their pregnancy test. So they have elevated beta HCG that's causing an increase in the thyroid hormone. So again, look for that issue. If there's a lot of beta HCG and a lot of free T4, then this could have been what issue? The choriocarcinoma, or it could be potentially a hydatidiform mole. Or sometimes it could just be general pregnancy, but usually it's more commonly the tumors. If that's the case then, these 2, we have to figure out which one it is. So if we find out that it's secondary, particularly we suspect that it's going to be pituitary, how do I determine if it is a pituitary issue? Get an MRI. If you get an MRI, that will be positive for a pituitary adenoma. If you suspect that they have high beta HCG and high free T4, it's most likely a uterine tumor. What do? get an ultrasound. Okay, so here you can get maybe a transvaginal ultrasound or an ultrasound of the abdomen, and then if you need to, there can be other tests like CT, MRI. But first test would be getting an ultrasound to confirm that there is some type of mass there. Okay, so now we've determined if it's primary versus secondary. The next thing is, after you determine this, do a good exam of the neck. Palpate for any thyroid nodules. Sometimes you may feel them. To be honest, sometimes you may not, because they're tucked deep within the thyroid tissue. But let's say that the nodules come back positive, or you palpate a nodule. If you palpate a nodule, there is two particular tests that you'd order. The first line test that you guys need to remember is going to be the radioactive iodine uptake scan. Okay? I'm going to put first line. If there's a contraindication to this, in other words, there's an iodine, like allergy to iodinated contrast, or they're pregnant or they're breastfeeding, those would be contraindications, then you go with an ultrasound with Doppler to look at the blood flow that's going to the area. And again, this is your second line test, okay? Second line. All right, you palpate a nodule, you send them to get the scan. What happens is tissue that's really hyperfunctioning is going to suck up a lot of iodine. If you suck up a lot of iodine into these tissue cells, they're going to appear dark on the scan. In Graves' disease, it takes up a lot of iodine all over the thyroid gland. So they'll have diffuse uptake. This would make you think of Graves' disease, okay? The next one is if you see one focal uptake, one area, one little nodule that's appearing dark. This would make you think of a toxic adenoma. If you see multiple areas, a couple different areas, a couple different nodules that are appearing dark, this should make you think of toxic multinodular goiter. And if you see no uptake, or you see very low uptake throughout the actual thyroid gland, this should make you think of particularly a thyroiditis. And this will lead you down further testing, okay? Now, the question that probably is coming up in your head is, Zach, what if the nodule is a cancerous nodule? There is tests that you can do. Here's the big thing. With radioactive iodine uptake scans, there's terms that you need to understand. If there's a lot of uptake into the actual tissue, it usually appears dark, and we call that hot nodules. And usually hot nodules are more likely to be benign and one of these issues here, particularly the toxic adenoma or toxic multinodular goiter. If there's a decreased uptake, usually that area on the radioactive iodine scan is less dark or white. And so we call those cold nodules. And those have a higher risk of being malignant. How do you determine if it's malignant? You get a fine needle aspiration and a biopsy with it to confirm that, okay? So we've now figured if it's primary, secondary. We then determined what the secondary issues could be. We then said, oh, if it's a nodule, that'll help me determining hyperfunctioning tissues. I can kind of determine from this test what's the problem, and then I might have an idea if it's cancerous or if it's a benign kind of nodule. After I've done that and I have no uptake or low uptake, I'm suspecting a thyroiditis issue. So now what I'm going to do is I'm going to check to see if some antibodies are present. Now, here's what's interesting. What other issue, what other disease had thyroid antibodies? Graves' disease. So the first thing that you would want to look for is you're going to order a couple different antibodies. You can order the TSH receptor antibodies, and this will be positive for which disease? Graves' disease. Okay, that's the first one that you want to be thinking about. But let's say that it comes back positive for TPO antibodies or thyroglobulin antibodies. This was associated with which two diseases? Hashimoto's most common one and postpartum thyroiditis. So Hashimoto's and postpartum thyroiditis. How do you determine the difference? Hey, did you give birth within the past year? All right, cool. So that could be something that you think about. Just look into their history. Again, Hashimoto's is going to be the more common cause associated with this. And another thing, postpartum is an acute onset. Hashimoto's is more chronic. All right, we've done the antibodies. We've confirmed Graves with antibodies and diffuse uptake, and that it's primary. But now there's other thyroiditis and other causes that we still haven't ruled out yet. So what do we do next? Order a serum thyroglobulin. All right, so the next thing is we got to check the serum thyroglobulin. Now, there was a reason why I harped all the time over there about that follicular cells, when they're getting injured, something spilling out of them, thyroid hormone, but what else is spilling out of the thyroid follicle? Thyroglobulin. And it's leaking into the blood. So whenever there is high serum thyroglobulin, what did we say was one of those issues? One of them was because of the thyroiditis. You were injuring the thyroid follicular cells. So one particular reason is going to be thyroiditis. Now, what were the different reasons for that? There was antibody related. There was viral related. There was drug induced. And there was iodine related. Do you guys remember the particular causes? Antibodies was Hashimoto's and postpartum. This would also be another way to confirm. Viral, what was that? Subacute granulomatous thyroiditis. What's another way to determine that one? You palpate the thyroid gland, it's tender. So that's another way that might lead into you saying, okay, viral, I had high serum thyroglobulin, I followed this all the way down, I'm trying to figure out which one it is. I palpate the thyroid gland, it's tender, and they have flu-like symptoms. They got muscle aches, they got joint pains, they had a low-grade fever. That might be viral related. Drug-induced, look at their medical history. Hey, you taking amiodarone? Hey, you taking lithium? That might be a reason why. Oh, they just recently got iodinated contrast. This could be why. So use your history to figure out the reason. The last reason that someone has elevated serum thyroglobulin is really interesting. Exact mechanism isn't completely understood, but it's due to struma ovarii. Remember that one? It was that ectopic thyroid hormone production that was coming from the ovary. There was a little tumor there that was having thyroid tissue producing lots of thyroid hormone. That tumor can also have, going through this entire pathway, but have elevated serum thyroglobulin. So also, what would you do? If you were like, oh, I don't know if it's thyroiditis or if it's struma ovarii, what do? Get an ultrasound. So you get an ultrasound of that area where the ovary is, and then you can also get a biopsy to confirm that there's actually thyroidal-like tissue in that area. The last thing here is you can prove a fool wrong, right? There's no injury, no damage, no leakage of the thyroglobulin out of the thyroid follicles. And so because of that, they maybe have a low serum thyroglobulin, or maybe it's even normal. In this situation, there's one last issue that we did not address. What was that last issue? Factitious hyperthyroidism. Or they could be taking hyperthyroid, they could be taking medications for hypothyroidism, but taking too much. The reason why you order the low, you check the serum thyroglobulin, is if it's low, it can prove that someone who is saying that they're not taking thyroid hormone medication is actually taking thyroid hormone medication if it's low. Okay? So again, that's the last thing. You shouldn't have to do this test unless you suspect that the patient is lying to you. Okay? So this is how we diagnose hyperthyroidism. Let's drill it home with treatments, and if we don't take care of this issue, the complication that it can develop into. All right, engineers, so now let's talk about the treatment of hyperthyroidism. It's actually really easy. First thing, symptomatic treatment. Best drug that we see in this situation, first line here, is going to be a beta blocker. Now, the preferred beta blocker to give in this scenario is going to be propranolol. Okay? And now, why is propranolol preferred? Okay? One of the reasons why is, remember that whenever thyroid hormone is circulating in the blood, it's primarily in the form of T4. How much percentage? 90%. When it gets to our tissue cells, it gets converted into T3, where then it exerts its effects on the nucleus and increases the synthesis of proteins that exerts all its metabolic and physiological effects, right? Guess what propranolol does? Propranolol comes over here and says, I'm not going to convert you T4 into T3, and now you can't form T3, now you can't exert your metabolic effects within the cell, and you can't increase the metabolism and all that good stuff. So that is going to be how propranolol works to basically help in situations of hyperthyroidism. After we've given the patient propranolol, the next thing is you got to give them anti-thyroid medication, something to help as well in this situation. And the two drugs that you guys need to remember here is going to be propylthiouracil, and the next one is called methimazole. Now, generally, this is the one that you're going to grab for first. It's more effective in patients with hyperthyroidism. The only exception for methimazole is that the only time we don't give it first line is if someone is in their first trimester of pregnancy. So the only time it's contraindicated is first trimester of pregnancy. And so in that situation, which drug would you give? Propylthiouracil. Okay? So both of these are very effective. We just prefer methimazole except for in that situation. Now, what do they do basically? Remember this enzyme here? This enzyme was called thyroid peroxidase. And what was the function of it? Remember, it was taking I'm going to put TG, thyroglobulin, and it was adding on what molecule? It was adding iodine into it, making thyroid hormone, right? We'll just put iodinated thyroglobulin. Taking that in and then eventually cleaving out of it the T3 and T4. So propylthiouracil is very interesting because what it does is the propylthiouracil inhibits the thyroid peroxidase. If you inhibit thyroid peroxidase, you cause less conversion of thyroglobulin and less conversion of iodine into iodinated thyroglobulin. You take less iodinated thyroglobulin back into the follicular cell, cleave less of it, and lead to a decrease in T3 and T4. That's one way. Methimazole does not perform this function. But what methimazole does is it performs the same function as propranolol, and so does propylthiouracil. So propylthiouracil and methimazole also exert another effect, and that is that they also inhibit the conversion of T4 to T3. And then if they have less T3, that means less activation on the genes to make proteins that increases metabolic and physiological activity. So to sum up, propranolol increases T4 to T3 conversion. Propylthiouracil inhibits T4 to T3 conversion, but also inhibits thyroid peroxidase. Methimazole inhibits T4 to T3 conversion. Beautiful. Methimazole preferred except for in first trimester of pregnancy. One last antithyroid drug. This last one is a radioactive iodine. So radioactive iodine, usually in the form of iodine 131. You give this drug, and what happens is iodine 131, when you take it in this kind of larger concentrations, it uses these iodine channels to get into the cell. When it gets into the cell, it starts releasing a lot of nasty little waves called gamma rays. And these kind of gamma rays or gamma waves that it's producing is actually going to start damaging the thyroid follicular tissue. As you damage this thyroid follicular tissue, it then does what? Decreases the conversion or decreases the synthesis of thyroid hormone. So what radioactive iodine or iodine 131 does is it gets into our thyroid follicular cells, exerts gamma rays, and then causes destruction of the thyroid follicles, decreasing thyroid hormone production. All right, we covered these drugs. Now, in the last situation, if someone has tried a beta blocker, tried an anti-thyroid medication, and has not seen any improvement, they're still refractory, we can try surgery. Or another reason you would try surgery is if someone has Graves' disease with ophthalmopathy. What was the ophthalmopathy problem? The exophthalmos. So what are the indications for surgery? There's actually three main indications. One is they have a goiter with compression on surrounding structures in the neck. Another is they have Graves with the ophthalmopathy, or they have refractory hyperthyroid. In other words, they haven't responded to the above treatments. In those situations, what we may do is cut a piece of the thyroid, one lobe of it, or cut the entire thyroid gland out. If we just cut one lobe, it's called a lobectomy, and that might help to get rid of some of these actual problems. Or sometimes that may not be enough and we have to remove the complete thyroid gland, okay? And if we're removing the complete thyroid gland, we're calling that a thyroidectomy. And this is how we would treat someone with hyperthyroidism. The last thing that we have to talk about is thyroid storm, which is basically thyroid toxicosis, whenever someone has too much thyroid hormone due to an underlying trigger. So thyroid storm is basically hyperthyroidism on steroids. It's where someone is producing massive amounts of thyroid hormone. What are the 3 most common triggers that I need you guys to remember that can cause thyroid storm? The 3 most common triggers are going to be an infection, okay? The second one is going to be some type of surgery, okay? Usually it could be thyroidal surgery or it could be some type of non-thyroidal surgery. And the last one is going to be trauma. These are the most common reasons for someone developing a hyperthyroid state. There is other reasons. I'll add them on. 2 other ones to take into consideration is what's called diabetic ketoacidosis and myocardial infarctions. Any of these things, what they do is they increase the already exaggerated sympathetic nervous system in someone with hyperthyroidism. So what's the overall effect of this going to do? It's going to increase the sympathetic nervous system even more than it already is with a person with hyperthyroidism. When that happens and you have this increased sympathetic overdrive, the main organs that I want you to remember that are really affected here is the heart. What it's going to do is it's going to produce some pretty high heart rates. So it can really induce some tachycardias, maybe even put a person into like atrial fibrillation. It also is going to increase the contractility, it's going to increase the heart rate, it's going to increase the blood pressure, and it can really induce a hypertensive kind of event. The problem is that if this continues and continues and continues and it's not being treated, the heart can become so weak because you're causing so much demand to it that it eventually can produce CHF and lead to hypotension and shock. So that's why it's very dangerous if not treated. So remember, hypertension and tachycardia are the big features. If not treated, it can lead to CHF, which can progress to hypotension. And this is called a high output CHF. It can also act on the central nervous system. And really what it's going to do is it's going to cause so much overdrive of the sympathetic nervous system that it's going to lead to confusion. It's going to lead to delirium. It's going to lead to an altered mental status. And worst case scenario, it can even put a person in a coma. The last thing I want you to remember is it acts on multiple cells, increasing the metabolic activity of these cells. If you increase the metabolic activities of these cells, you're going to do what? Increase the body temperature. And if you increase the body temperature very, very, very high, what's that going to lead to? Fever. So the classical features that you see is usually someone with hyperthyroidism who's had an infection, DKA, myocardial infarction, surgery, trauma, causing adrenergic hyperdrive, hypertension, tachycardia, altered mental status confusion, and significant fever or high body temperature. You now suspect thyroid storm. Go through the same diagnostics we just mentioned above. After you've done that, you got to treat them. You know what the treatment is? The 6 P's, baby. Hit them with what? First thing is hit them with propranolol. Okay? That's going to do what? It's going to shut down the conversion of T4 to T3. Next thing you're going to give is propyl thiouracil. That's going to inhibit the conversion of T4 to T3, as well as inhibit the TPO, the thyroid peroxidase. You're going to give them prednisolone. Now, the reason I put this one is I want you to remember primarily corticosteroids. They can give multiple types of corticosteroids. I'm just telling you prednisolone so that you remember corticosteroids. Okay, so propranolol, propylthiouracil, prednisolone, and potassium iodide. Okay, also known as Lugol's solution. Okay? I'll explain this one last because there's a mechanism that you need to know, okay? I'll talk about it really quickly afterwards. The next thing is plenty of fluids. Why? is if someone is sweating a lot because they have a high body temperature, but they have a high fever. They also have high amounts of diarrhea if they have hyperthyroidism. They're losing lots of fluid. You need to regenerate, resuscitate their fluid levels, okay? The next thing is they have high fever. We don't want to fry those brain cells and those proteins, so we need pyretic control. And so what do we do with that? Sometimes they'll call an ice alert, right? But you can start them on acetaminophen, also kind of abbreviated as APAP. And then the last thing is you can try cooling measures. Sometimes it may be cooling packs, sometimes it may be cooling blankets, sometimes they even have to do like a severe, maybe like an endovascular therapy. But cooling measures are going to be the next thing that you employ. Now, I wanted to take a quick second to talk about this potassium iodine. The only reason I need to is because it's high yield on your exams. What happens is if you take, for example, that follicular cell, and what you do is you take this follicular cell that's producing lots of thyroid hormone, right? It's producing lots of thyroid hormone. What you can do, and this may sound very it sounds confusing in a little bit, but watch what happens. I give them more iodine, like a lot, sometimes greater than 5 milligrams. And I load this into these thyroid follicular cells that are producing a lot of thyroid hormone. What happens is as you load them up, it shuts down the iodine channels. Hey, too much iodine in this cell, no, don't bring any more iodine in here. We can't handle it. So it shuts down the iodine channels. Then it inhibits the thyroid peroxidase. Hey, no more thyroid peroxidase activity. We don't need to make any more thyroid hormone. And that effectively lowers your thyroid hormone. The reason I wanted to mention that is this produces what's called the Wolff-Chaikoff effect. Opposite of the Yod-Bastau phenomenon, okay? This finishes our discussion on hyperthyroidism.